Welcome to the 6-Minute Shoulder. My name's Duncan Tennant. I am a consultant shoulder and elbow surgeon at Cleveland Clinic, as well as being a professor of orthopedic education. Shoulder problems are common in general practice, and there are an alarming number of different diagnoses that can be made. Time is of the essence, and you need to have an efficient way of managing these problems. The aim of this talk is to remind you of the common diagnoses and take you through a fairly simple diagnostic algorithm and show you where we are in the current treatment of these things. This very busy slide is actually a simple summary of everything you need to know. It takes you through the symptoms with a presumptive age that can be quite useful, a diagnosis, and then the primary management, and then really what we're going to do with them if they fail primary management. We'll break this down diagnosis by diagnosis, starting with instability. Typically, these are younger patients, and they will tell you what the history is. They will tell you that they've dislocated or that they feel apprehensive. If it's a first-time instability, then physiotherapy is a very reasonable option, and there's no real gain in immobilizing them. If they're recurrently unstable, then really the only solution is going to be surgical stabilization, and they should be referred on. I wouldn't worry too much about imaging, as we'll sort out what we think is the most appropriate when we see them. Frozen shoulder is another very common diagnosis, typically middle-aged, and they will describe a reduction in both the active and the passive range, typically with an early painful phase, which then moves on into a painless stiff phase. The important feature is external rotation is lost and that they will have a normal X-ray. In the first instance, symptomatic treatment with non-steroidals, a trial of physiotherapy, as the diagnosis can be a bit tricky in the early stage, and if it's available to you, hydrodilatation. This may not be an option in your practice, and if it isn't, then do refer on, as we can then see them for either a hydrodilatation, or if that fails, a manipulation under anaesthetic, or potentially an arthroscopic capsular release in the very difficult cases. AC joint pain is very common and actually very easy to diagnose. The patients will localize pain to the region of the AC joint with one finger, and they're typically tender. They describe pain in the high arc range, and often in the younger patient it's accompanied by a history of weightlifting or bench pressing. The treatment, like much of them to start with, is non-steroidals, and interestingly physiotherapy has a role here. If you're able, a steroid injection into the AC joint may be beneficial, but it's quite difficult to do. Ultimately, if this doesn't work, then arthroscopic excision of the distal clavicle is a very successful procedure and actually very short recovery period. Arthritis is often an easier diagnosis to make in the older patients. They present with a, quotes, frozen shoulder, in that they have a reduction in both the active and passive range of motion, which is typically accompanied by some pain. Obviously, in these patients, they will have an abnormal X-ray. If conservative treatment, which is non-steroidals and physiotherapy, don't work, then I would not recommend a steroid injection into the joint, as A, this won't last very long, and B, it increases the infection risk if ultimately they come to a shoulder replacement. I've included biceps rupture, which isn't on the main algorithm, just because they are quite common and are worth knowing a little bit about. They can be proximal, which is the long-headed biceps, or less commonly, but more importantly, they can be distal. So the long-headed biceps rupture is more common in older patients, often not related to any trauma, but can be seen in weightlifters. They have the classic Popeye sign, and typically these can be left alone. There's a slight reduction in supination strength, but often this isn't significant. In the younger patient, we may consider fixing them, but this is fairly rare. The distal biceps rupture is more significant. It's less common. It's typically the younger patient. Often there is an element of force. They've dropped and caught something, or they're playing rugby, or occasionally the weightlifters. There's often marked bruising around the medial aspect of the elbow, and there's a clear reverse Popeye deformity. This really should have a fairly urgent surgical opinion, as particularly in the right side and in manual workers, it can be quite disabling. In the middle-aged on the left side, we may not need to fix it, but this just needs an urgent surgical discussion. Now I'm going to spend a little bit of time talking about rotator cuff pathology. This is very common, and the presentations of subacromial impingement and rotator cuff tears are often very similar. There are three distinct patient populations. There's the middle-aged, which is impingement and the classic rotator cuff tear. There's the young, in whom they have a traumatic tear, and the elderly, who tend to have the larger cuff-deficient shoulders. If we look first at the most typical form, which is the middle-aged patient with rotator cuff pain, which is that classic lateral to the acromion, painful arc on abduction, and they have positive impingement tests, although I wouldn't spend too much time on those. It's very difficult to know whether they have impingement or a small to moderate rotator cuff tear on clinical examination, but actually in the initial phases, the treatment's all the same. It's non-steroidals, a trial of physiotherapy, and a steroid injection to help with the physiotherapy. If this doesn't work, they're going to need some further imaging to try and work out whether it's impingement or a tear, and then ultimately either a subacromial decompression, which actually isn't very common, or a rotator cuff repair. An important group to be aware of are the traumatic cuff tears, and although these are labelled as young, this is really anybody who's physically active. There is a history of an acute event. This is classically slipping, falling over skiing, coming off the mountain bike. They describe the same symptoms, which is pain lateral to the acromion. Often they have more pain than you'd see with the others, and they can't abduct. If you suspect that there may be an acute tear because of the history, then they need urgent imaging, which either you or we can organise. And these patients don't do well with conservative treatment. So we usually recommend an acute cuff repair. Now, by acute, we mean several months. There isn't the immediate urgency, but they certainly shouldn't be missed. Finally, there are the older patients with rotator cuff pathology. They have the same symptoms, the same painful arc and positive impingement tests, but they quite often will have either a chronic rotator cuff tear or an acute tear on a chronic tear background. Again, the treatment in the first instance, non-steroidals, physiotherapy, try a steroid injection. The difficulty with this population is even if they have a smaller tear, they're often not amenable to surgery for biological reasons. Some of them do very well with what's called Ainsworth physiotherapy, which is recruiting the anterior deltoid. It's a fairly standard program. A suprascapular nerve block is a very good way of getting rid of the pain. We can either do this in the clinic or they can be referred up for ultrasound guided injections. And ultimately, a reverse shoulder replacement is surprisingly a very good option in these people as they get back to activity very, very quickly, and it's very reliable. So in summary, as I said at the beginning, there are a large number of shoulder conditions, but it's relatively easy to make a broad diagnosis quite simply. There isn't a huge amount to be gained by spending a lot of time on clever examination of the shoulder, and the early management is relatively simple. And as long as you pick up the urgent ones, everything else can have a trial of conservative treatment and see how they get on. So here is that algorithm again. It doesn't include the biceps, but it includes all of the other stuff, just to give you an idea of how to make the diagnosis, how to manage them acutely, and what we can offer if you send them on surgically. Thank you very much for watching this. I hope you found it useful, and do let me know if there's anything else you'd like to be included.